Thank you very much, Deborah, for a fascinating review of both some of the key issues that are facing about half of us in the room. I've been a member of AARP for 16 years now, and I'm glad they're there. And particularly now when there are so many political attacks on things that are going to be important to many of us in the room, probably all of us in the room. We're going to do something slightly different than we've ever done before in an open classroom in the 3.5 years we've been running it. And that is, I want to introduce you to brand new research. You're on a university campus here at Northeastern University. We educate thousands and thousands of undergraduates. We educate thousands and thousands of graduate students, and we hope we're educating many of you. But we also are deeply involved in research. We're a Research One university, a top-tier university for doing research. And I've, as you know, had the Dukakis Center for Urban and Regional Policy, and we do a tremendous range of research, but we've recently begun to do something brand new and very exciting. And since we were talking about the question of Social Security, and the issue of health care keeps coming up over and over again, as in Deborah's talk, as in Alan Clayton Matthews' talk, I thought I would introduce you to the newest model, literally less than a month old, that we're developing here at the Dukakis Center for the Bipartisan Policy Center in Washington, D.C. So this is going to be, in the next 20 minutes, something like a true graduate seminar. This will be no different than what I would do if I had a group of PhD students sitting here in the classroom. Several years ago, members of both parties, the Democratic Party and Republican Party, got together and decided to create something called the Bipartisan Policy Center in Washington. The people who began it were senators like Senator Tom Daschle, a former senator from South Dakota, Senator Bill Frist, a Republican from Tennessee, former Governor Ted Strickland from Ohio, former Senator Pete Domenici from New Mexico. And the idea, strange as it may sound today when you look at the Congress, is that there are ideas that are coming out of the Republican Party and the Democratic Party that in fact are good ideas, and that people could work together on these the way at least we used to. The very first thing that the Bipartisan Policy Center devoted themselves to was to do one of the two major reports on the federal deficit. One was done by a commission set up by President Obama. This was done independently by the Bipartisan Policy Center. They employed Brookings Institution economists to do the study for them, headed up by Alice Rivlin, the former director of the Congressional Budget Office, and Senator Domenici. When they finished that study, and you may have read about it in the Wall Street Journal, the New York Times, the Boston Globe, they came to the conclusion that we're going to need dramatic cuts in spending in the future and probably significant increases in taxes to make sure that we don't end up spending over $1 trillion a year simply to pay interest on the national debt. But what they also found was that if you looked at all of the spending, what really was making all of the difference was not Social Security. It wasn't all of the discretionary programs that we get from the Department of Labor or the Department of Housing and Urban Development or the Energy Department or the EPA. It was health care. And that health care was bankrupting the nation. And so they decided to set up a second major project, of which they're pouring several $1 million, into looking at the health care system and how we might change it in ways that will allow us to afford health care without literally breaking the bank. And in doing this, they've created 7 task forces, and the very first one of those is on the health care workforce. A group of healthcare experts, I'm not one of them, from around the country bid on one of these contracts to do the healthcare workforce, including the Dean of Nursing here at Northeastern University, Carol Kenner, a sociologist and a team of sociologists at the University of Illinois Champaign-Urbana, led by Noreen Shugru, a healthcare expert at the City University of New York, Dana Weinberg, and Margaret Heldring from the University of Washington in Seattle. And the idea was to take a look at what our needs would be in terms of the healthcare workforce, as well as the kind of training that we would need for the future of the workforce. But they turned to me, particularly Carol knew of my work, because they wanted to have, one, a guy on the team, and number two, they wanted to have somebody who was a labor economist, which I am. And what I proposed to them was that we do two studies. One, to look at the demand for healthcare workers into the future. And we did a study with a group called Civic Ventures, which shows that we were going to need, just between now and 2018, over 4 million additional workers in that industry. And it's not clear we'll have them all if we want to depend on young people to fill those roles, as Deborah suggested. But the second thing I suggested is that we needed to develop a powerful simulation model that would allow us to test various counterfactuals. A counterfactual is a what if. If we did X, what would be the impact on the healthcare cost? There are several models like this around the country. A big one is built by the Rand Corporation in Santa Monica. But I decided, since I didn't want a black box in which I did not understand what was going on in the model, that the best way to do that was to start from scratch and build a model that we could all understand. The model I'm going to show you is a massive model that is built on a very, very sophisticated econometric piece of software called Microsoft Excel, a spreadsheet. It's all a big spreadsheet, although if I were to print it out in 12-point type, it would be much bigger than either one of these screens, in fact, bigger than both screens together. So what I want to do is give you an idea of what this model looks like. There are 4 factors that will affect healthcare costs into the future. Two of them are demographic. One is simply population growth. We're going to have about 70 to 80 million more people living in America by 2030 than live here now. It'll be about almost 390 to 400 million people. We had 308 million people. That's the official number of the 2010 census. The second factor is one we've been talking about all semester. It's demographic shifts in the population. People getting older, changes in the gender composition, changes in the racial and ethnic composition, as well as changes in where people live. Certain areas of the country are a little cheaper than others in terms of health care. But there are 2 other factors that are really important. One is potential changes in health care utilization. What I mean by utilization is people using more units of health care, seeing doctors more often, having more MRIs, going to the eye doctor more often, going to the emergency room more often. That is, more units of health care per capita. It has nothing to do with increasing the price of care, just more quantity of care. And then the fourth is changes in per capita cost of health care delivery, because the cost of health care, as you know, is rising, the price of health care is rising faster than normal inflation, either the consumer price index or the GDP, gross domestic product deflator. So what we wanted to do is, first of all, take a look at these 4 factors, run out our model starting with the population in the year 2000 and take it out to 2030 under the conditions of what the census has projected in terms of potential expected changes in the population, and then also taking into account the current cost of health care per capita, as you'll see, for various kinds of health care provision. Inpatient hospital stays, dental visits, eye doctor appointments, physician appointments, and so forth, right? And the idea is you build a simulation model out to 2030 based on current costs, based on current projections of the population, and having done that, we will then be in a position in the future this summer and in the fall to say, okay, what if? What if we replace some docs, MDs, with nurse practitioners? Or maybe a little more complicated one. What would happen if we hired 25,000 quote-unquote patient coaches that would help people who have diabetes, who are obese and have, or overweight and have diabetes, to perhaps help those people get in shape and reduce the incidence of diabetes, which is a very, very expensive disease. Or help somebody like me keep my cholesterol and blood pressure down, and to make sure I'm taking my medications so I don't end up in the emergency room with a stroke or a heart attack, and then spend God knows how long in rehab after that. That's a little more complicated. But what I want to do is show you how it works. What we did is we used data from the census, data we actually talked about in this class, and data for population projections through 2030. And you can think of, how many of you have ever used Excel or another spreadsheet? Okay, so you know what Excel spreadsheets look like, right? Think of each cell in the spreadsheet as having a particular gender, male or female, a region, north, east, south, Midwest, and west, an age category, age 18 to 24, and to see it over 7 years from 2000, 2005, 2010 through 2030. So one cell will be a male, 18 to 24, living in the Northeast, right? That's one cell. And we know how many people are there now. We know how many people there were in 2000. We could project it all the way out to 2010. We now know what is in 2010. And then based on census, we can see how many people will be in each of those cells over time. And of course, what's going to happen is some of those cells are going to grow much faster than others, like the cell of people over 65, right? Like the cell of people living in the Southwest. Okay? So we're going to be able to do that. Total cells in this population matrix, pretty small, 336. Okay? And we'll keep track of changes in the age distribution, changes in the gender composition, and the regional distribution population. In the future, we may be able to do it by race as well. One little portion of this matrix you see on the screen. And I've taken just one little piece of that portion, and I've put it down here, and it shows you what the population would be projected for men by age group living in the Northeast, which is the New England plus the three mid-Atlantic states, New York, Pennsylvania, New Jersey, 9 states in all. So we see the population going from about 26 million, if you see that over here, up to about 27.8 million, not much growth, by 2030. But if you see it by age, you'll see we go from about 2.9 million to about 5.2 million men living in the Northeast who are 65 years and older. So you can see a population growth, you can see the shift. Okay? In fact, if you look at the United States as a whole, and I've taken one little piece of that whole matrix to show you, what it says is that we would expect to see between 2000 and 2030 an increase of about 29% in the male population, from about 138 million in 2000 to about 151 million this past July to about 179 million by 2030. And you can roughly double that to get you to the total population of men and women. So about 360 to 365 million, almost 370 because there are more women than men. There'll be a 29% growth in the male population, according to the census, between 2000 and 2030. For those under age 5, given birth rates and immigration, we expect about a 26% increase in boys, under the age of 5. 15% growth in the number of boys 5 to 17, a 20% growth in those 18 to 24, and then almost no growth in 25 to 44-year-olds. These are people in their prime working years. We're going to have 9% more of them. But we're going to have 35% more people 45 to 64, and we're going to have more than a doubling from 14 to 31 million in the number of men aged over 65, according to this. Okay? Gives you an idea of what's going on. Okay? If we look at the Northeast, we can see that we actually are projecting almost no growth in young males. Overall, only a 7% growth versus 29% for the country. Only a 2% growth of males under 5 years. An actual decline in the number of men. A decline in the number of men over the next 20 years. Minus 6% among 5 to 17-year-olds. Minus 10% of those 25 to 44. And then a very large growth, about 75%. Right. So we're not growing very fast. We've seen that before. And we're particularly, according to this projection, seeing actually an absolute decline, and I might say, among men and women in their prime age. Who will do the work? Who will pay the taxes? For Northeast, that's still going to be a problem. Okay? That's one set of matrices. We then go into a really spectacular set of data. It's collected by the federal government at the cost of tens of millions of dollars. They've been doing it since 2000, and it's called the Medical Expenditure Panel Survey. And they keep track of literally hundreds and hundreds of thousands of people, and they're able to gather information from with their consent from hospitals, from emergency rooms, from dental clinics, from others, about how much is spent on a category of individuals, or on each individual in the survey, each year. And using that, we know what the average expenditure will be for a particular kind of health care for a particular demographic cell. Okay? This survey takes information on your demographic characteristics, your age, your race, your gender, your health conditions, your health status, the use of medical services, charges and sources of payment, insurance, private, public, Medicare, Medicaid, access to care, even some questions about how satisfied you are, what your health insurance are, and of course some things on income and employment. We're going to use those data. And indeed, it keeps track of 9 different kinds of healthcare spending. You know, from hospital inpatient stays, pretty damned expensive, to dental visits, to home health care, to prescription medicine, vision aids, and other medical equipment and services. Okay? Keeps track of every one of those. What that means is that working with the MEPS data starting, Medical Expenditure Panel Survey data beginning in 2000, we're able to look at each medical expenditure for each type of medical service for each year, which gives us, for each year, 432 different cells. Okay? One cell in our matrix, 432 for each year between 2000 and 2030. So one of those cells will be how much was spent on in-hospital stays for 18 to 24-year-old men living in the South. That's one cell. 432 of them. And if you look at it over the 7 years from 2000 to 2030, we have a little matrix with 3,024 cells in it. Okay? So we have this big matrix of demographics over here, and we have another big giant matrix of expenditures over here. People, dollars. Okay? What does it show us? Well, if we just look at a portion of this gargantuan MEPS-based expenditure matrix, you'll see, for example, these data tell us how much is spent on average per capita for each of these demographic cells. Let me show them to you in a little bigger format. So overall, looking here, I'm just looking here at men for the whole United States, the average expenditure for all types of health care was $2,065 for all men regardless of age. It runs from a low of $588 for 18 to 24-year-olds. Right? Goes up to about $865 for kids under 5, boys under 5, and then up to about $1,269 for 20, up to over $3,200 for 45 to 64-year-olds, and then over $6,000. That's average per capita spending on health care for every male over age 65 and over in the United States. So when you move from being a 18 to 24-year-old to being a 65-year-old male, on average, you go from $588 in spending to $6,100. So if you just look at those numbers, you can, at the first glance, you'd say, wow, if we're really growing old quickly, we're going from cheap people on medical care to really expensive people on medical care. What will this do to the budget? So what do? We take one matrix here, this gigantic matrix of demographics. We take another matrix here of expenditure per demographic group, and we multiply it together, right? If you want to do that on a hand calculator, it will take you about 17 years. We can do it in the computer in about 30 seconds, okay? It's nice to have computers. So we can multiply these guys out. And what it does, it's going to give us the total amount of expenditure, in this case in billions of dollars, adding up to trillions of dollars, that's with a T, for each kind of cell, and we can do it for each kind of medical expenditure, as you see here. So, for example, according to this, if we just have a projection of our population and demographic change, no inflation and no increase in utilization, right? We're using the data from 2000 and assuming there was no increase in the number of units of care per capita, right? And no change in utilization. We'll go from dental visits costing us about $112 billion in 2000 to $145 billion in 2030 just to get your teeth cleaned and fill a few cavities and put in a bridge or two, okay? If we look at hospital inpatient stays, we go from 462 billion, if you can see that number, up to about 719 billion, or 0.7 of $1 trillion. Let me just give you that in context. The entire gross domestic product of the United States today is $14 trillion. Okay? If we add all of that together, again, assuming no inflation and no increase in utilization, we go from $1.26 trillion in 2000 to about $1.4 trillion today to about $1.9 trillion in 2030. Okay? So, these are the first steps. This gives you an idea of what the different costs are. Inpatient stays for 18 to 24-year-olds, $287 on average, to $2,692 for those over 65. Home health care, $5 for the youngsters, $365 for people like me. Prescribed drugs, $109 for the youngsters, an average of $972, 9 times that amount for somebody 18 to 24. Okay? So simulation 1 says let's keep the cost constant, the prices constant, and let's just do demographic change. So it's the pure impact of demographic change, right? We're not going to increase the population. We'll assume the population, the total population in 2030 is exactly the same population that we have today, except it's older, as we project it to be. It's changed a little bit in terms of gender, and it's changed a little bit in terms of region. Just that demographic change will cost us about $200 billion. Big number, right? $200 billion just because of demographic change. Everything else has been held constant, including utilization, inflation, and population growth. Okay? Let's do another simulation. Let's grow the population, but keep the demography constant, right? And no inflation, no increase in utilization. So if we just have the population grow, but they have the same demography as we have today, right? No more older people than we had in 2000. We add about $400 billion to the cost of health care. $400 billion, just because of population growth. Let's do a simulation number 3. What we're going to do here is we're going to take the population growth and add the demographic change together. Now we got an older population that's also aging. Whoa. That takes us from $1.2 trillion to $1.9 trillion, an increase of $606 billion just because of demographic change. Wow, $606 billion just because of demographic change, right? Sounds like a big number. It turns out to be not a very big number. So now let's ask the question, what happens if we have medical care inflation equal to the inflation we've had over the last few years, which is 2.2% higher, 2.2 percentage points higher than the normal inflation rate for everything else? Our homes, our gasoline, well, don't count gasoline right now. Food, don't count food right now. But all the other things, right? It goes from 1.2 trillion to 4.2 trillion. This is just the impact of inflation. That's holding the population constant. If we didn't add a single person, if no one changed their age or their gender or where they lived over 30 years. So wouldn't that be nice? You're 38 today, you're 38 in 2030, right? All that happens is we get the normal inflation rate that we've been seeing in healthcare. That is going to grow our healthcare costs by 234%. Now, what will happen if we put them all together? We allow the population to grow, we allow the population's demographics to shift, and we allow expected cost inflation. We're up to $6.2 trillion. By the way, that's almost 50% of complete GDP that we have today, right? We add $5 trillion. That's a lot of zeros with a 5 in front of it between 2000 and 2030, okay? And if we look at all of them together, you'll see that, as a matter of fact, as Alan Clayton Matthews suggested a couple weeks ago, it ain't demographics, it's cost. As it turns out, we haven't yet figured out in our simulation model how to calculate increased utilization. We're close, we got a team working on it, but we're pretty sure that when we increase it also for utilization, that number will not be 6.2 trillion, it will be north of $8 trillion. We'll go from 1.2 trillion to over $8 trillion just because we're using more medical care per person. Okay? So, how well did our simulation model work? The neat thing is we started the simulation model in 2000. That's 10 years ago. So we actually can ask, did our simulation model actually track real spending, at least up till the present? And the answer, thank God, is, that's a technical term, that it did. You'll notice that when we used our simulation model, and then we divided it by GDP, which is the way we normally talk about the cost of something, because the numbers, percentage of GDP. In the year 2000, according to our simulation estimate, we came up with 12.7% of GDP. The closest number we had was for 1999, and it was 12.5%. And it's likely that between 1999 and the year 2000, 1 year, we probably nailed it at 12.7%, or very close to it. That is staggeringly close. It is so close to be downright scary. You're not supposed to have research numbers which on the very first simulation, without fooling with it, came up with that. We then project out to 2005. Remember, we were using 2000 data and just projecting. We projected 14.7% of GDP, up from 12.7. It was actually 14.5. Whew! We then projected the 2010. We came up with 16.8%. The actual number is 17%. And then we continued projecting, and you'll see that our projections, 17.3, 18.6, 20.2, 21.1, fall behind other projections that have been made by the Congressional Budget Office. By 2030, they're projecting 28%, right? That's more than double the percentage of GDP in 2005. We only come up with 21.1%, and the reason for that is we haven't taken into account increased utilization. So the missing factor that we haven't been able to put into our model is this increased utilization rate, which increases over time, in part because of technology, according to CBO. Okay? So our next step is going to be, once we get the utilization thing fixed, we're really close, it's really neat to see that done, is, okay, now we're ready to have fun. This is all just, you know, foreplay for researchers, right? This is not the real stuff. So what can we do? Now we can start saying, okay, let's look at some counterfactuals. As I said, what happens if we replace some with some of my doc friends with nurse practitioners? What would be the impact on total cost? And how are we going to do that? By working with our doctor friends and nurses friends and all that, and some other researchers, we're going to try and see how the impact of that will change those dollar figures in the MEPS matrix, right? So if you go to a doctor's visit and you see a nurse practitioner rather than seeing an MD, that's going to lower that by a little bit. We don't know how much yet. But as we are able to change the individual dollar units in each of those cells, we can then multiply the whole thing out again, let the computer zip and zap, we'll get a new number. What happens if we use more generic prescription drugs? We know the difference between, on average, the cost of prescription drugs and the original drugs they replaced. How big of impact will that have? What would happen if we had a reduced use of emergency rooms? What happens if we had an increase in home care services? What happens if we shifted from hospitals, in-hospital service in teaching hospitals like the BI or MGH to community hospitals in Sharon? What would happen if a lot of different things happened? There are literally thousands and thousands of simulations we could do with this. But having done this, what we're going to be able to do is test out what are the kinds of cost savings we get, given that we absolutely have cost savings. We have to. 28% of GDP means we have no money for education, no money for transportation, no money really for anything, right? So we have to do it, but the real question is where are you going to get the savings? So what I've shown you is just a glimpse of how researchers actually can develop a model like this using lots and lots of data, crunch it in ways that you can finally set up a counterfactual simulation model, and now working with people who can help us decipher what the cost savings would be if we did X, Y, or Z, or X and Z, or Y and Z, or maybe Q and S. We should be able to say, here's where we can make some real inroads and get us some numbers that people can start playing with. And there you have it. Thank you very much.